Thank you for your interest in this lecture. This lecture will discuss the management strategies available for compromised first permanent molars. My name is Desmond Ong, and I'm from the state of Queensland in Australia. I have no conflict of interest to disclose. My private practice is in Townsville, which is in North Queensland, and I have three wonderful practice partners: Jeff Stanton, Paul Hanrahan, and Linda Ton. I'm also lucky enough to work for the University of Queensland in Brisbane, and I have had two fantastic mentors over the years, Professors Terry Freer and Christopher Ho. This is the Oral Health Centre at the University of Queensland. The first permanent molar is a commonly compromised tooth and has been reported to be the most caries-prone tooth in the permanent dentition. A historical paper has reported that more than 50% of children over the age of 11 years have some caries experience in this tooth. And this 15-year-old patient demonstrates severe compromise of the first permanent molars. There is a significant risk factor for severe compromise, and that is the presence of hypomineralization. And this is the same patient as the previous slide 4 years earlier. Hypomineralization has been associated with a nearly 14-fold increased risk of caries, and it appears to be a global problem. This paper by Zhao and others recognise that molar incisor hypomineralization is a global disease affecting young people in multiple countries and has a global prevalence rate of 14.2%. This is an excellent reference and resource, the D3 group. And this is an excellent summary and review paper on the etiology of molar incisor hypomineralization. Dental enamel has a lack of metabolic activity once formed, meaning disturbances during development can manifest as permanent defects in the erupted tooth. Disturbances in the initial matrix secretion phase will most likely present as quantitative or morphologic defects, also known as hypoplasia, whereas disruptions to the calcification or maturation processes may produce morphologically normal but structurally or qualitatively defective enamel, also known as hypomineralization. Clinically, hypomineralization presents as a qualitative defect, and the enamel may demonstrate rapid post-eruptive breakdown due to the mineral quality deficit, whereas hypoplasia is a quantitative defect and may present as a quantity deficit of enamel thickness. The etiology of molar incisor hypomineralization has been linked to early childhood or prenatal conditions such as middle ear infections, chickenpox, respiratory diseases, medications, and environmental exposures. There may also be a genetic predisposition. This wonderful paper by Sandler and Murray discussed the removal of first permanent molars and orthodontic treatment. And in 2010, Joseph Blakely and myself wrote this paper for the Australian Dental Journal. For an adolescent patient with compromised first permanent molars, we can accept their likely entrance into a restorative cycle or plan for removal with ideal timing or perhaps non-ideal timing and orthodontics. This is an excellent paper by Coburn and others, which is a guideline for the extraction of first permanent molars in children. This paper from the Journal of Pediatric Dentistry states that it is reasonable to assume that in some cases managing compromised first permanent molars is more effective with orthodontic treatment versus the lifetime cost of restorative care. Therefore, we must weigh up the compromised molar's life expectancy and the patient's life expectancy and ask ourselves, is there likely to be a significant time discrepancy between the two? This is more likely to be a dilemma for an adolescent patient. There are scenarios where extraction of compromised first permanent molars may be considered. When they are extensively carious or non-restorable, significant hypomineralization, where there is crowding and heavily restored first permanent molars and the adjacent premolars are healthy. Endodontically compromised first permanent molars, especially in an adolescent patient. Compromised first permanent molars in patients with significant posterior arch crowding. Scalene divergent malocclusions, also known as patients with a dolichofacial vertical morphology. Patients with an anterior open bite tendency. From the cost-benefit perspective, we know that orthodontic treatment involving the removal of first permanent molars is more technically demanding and may involve more complicated treatment mechanics due to the larger extraction space that requires closure and the increased treatment duration potential. Despite the increase in technical difficulty, the extraction of compromised first permanent molars with questionable long-term prognosis can be justified in conjunction with appropriate orthodontic treatment, especially if extractions are warranted for crowding or bite correction for that individual patient. Timely removal of compromised first permanent molars can greatly facilitate and simplify subsequent comprehensive orthodontic treatment through maximising spontaneous space closure, through facilitating the correction of the malocclusion, or improving the predictability of appropriate molar autotransplantation. Is there such thing as ideal timing? For Class 1 cases, it may be highly desirable for maximum spontaneous extraction space closure to be achieved. Ideal timing has been suggested in the literature. However, no significant scientific basis for these suggestions. Rather, such suggestions more likely represent clinical intuition. This paper by Teo evaluated the spontaneous space closure after the extraction of first permanent molars and reported that in the upper arch, extraction space closure is often complete, regardless of the second permanent molar development stage. However, in the lower arch, such complete space closure is not as common. Even when extracting the first permanent molar at the ideal stage E, which is the ideal bifurcation developmental stage of the second permanent molar. Radiographically, this is what the ideal bifurcation developmental stage is for the lower second permanent molars when removing the compromised first permanent molars in the lower arch. This is the same patient 14 months later, demonstrating very favourable mesial eruption of the lower second permanent molars. And clinically, we can see the eruption of these teeth. Teo stated that the timing of first permanent molar extraction based upon the second permanent molar development stage may not be as critical as current guidelines suggests, and that spontaneous space closure in both arches can still be achieved even when technically too early or late. In the upper arch, complete space closure is mostly to be expected regardless of extraction timing. However, in the lower arch, even when the first permanent molars are extracted at the generally accepted optimum stage of second permanent molar root development, a significant proportion of patients will still not achieve ideal space closure. Therefore, the clinical decision making is not always straightforward, and the situation varies between the maxillary and mandible. There are several influencing factors to be considered. The final treatment plan may also require adjustment in these scenarios. When looking at cases with compromised first permanent molars, the first decision is whether to maintain or extract that molar. And these are the situations where maintaining the compromised molar may be more desirable. And these are the clinical scenarios where removing the compromised molar may be preferable. There are many factors to consider for compromised first permanent molar cases. These are the various management strategies for compromised first permanent molars in adolescent patients. Perhaps an underutilised management strategy is that of molar autotransplantation. However, the technique and timing are critical. This 16-year-old patient has essentially a class 1 malocclusion and compromised upper first permanent molars. These teeth were recommended for removal, and comprehensive treatment has mesialised the upper second permanent molars. And we can see a favourable eruption path for the upper third molars. No significant profile effects have been noted. And at the completion of treatment, we can see complete mesialisation of the upper second permanent molars and now partial eruption of the 1/8. This patient presented for consideration of retreatment with mild crowding in a class 1 occlusion. The patient also would prefer slight reduction in the incisor proclination. The main issue was that the 2/6 was significantly compromised with a deep restoration. Therefore, with appropriate informed consent, the 2/6 was recommended for removal in addition to the 1/5, 3/5 and 4/5. And during treatment, we can see now the upper and lower incisors angulated more ideally. The 2/8 has now erupted into functional occlusion. And at 19 months, we can see a very pleasing upper incisor position. During treatment, the 2/7 was completely mesialised and the 2/8 has erupted clinically. At 20 months, the treatment was complete. And we can see the 2/8 is clinically erupted and now is in functional occlusion. This paper has found that for adolescent patients, orthodontic treatment with extraction of the first permanent molar in the upper arch results in significant improvement in the position of the upper second and third permanent molars, and that normal eruption of the upper third molars can be expected to be highly likely. For this 11-year-old patient, there was significant restorative treatment provided 18 months ago. And there is a clear evidence of lack of space for the 1/3, 2/3 and 4/3. Radiographically, we can see the compromised 1/6 and 3/6 impacted developing second molars, lack of space for the permanent canines, and likely future impaction of the third molars. It was recommended that the compromised first permanent molars be removed and balanced with the remaining first permanent molars. Close the space orthodontically and then reassess the likely need for a later phase of lower orthodontic treatment to upright the 3/8 and 4/8. This is another patient who provides an example of a later phase to upright the 4/8. And a TAD or temporary anchorage device has been placed for indirect anchorage. Back to this patient at 12 months. The canines had been aligned and the upper and lower second permanent molars had been mesialized. We can see now at 12 months, and in particular, the 1/7 and 2/7 will require further root reangulation. No significant profile effects despite the multiple extractions, and at 21 months, the active treatment was complete. Complete mesialization was achieved. From 12 months to 21 months, we can note the improvement in the root angulation of the 1/7 and 2/7, which is expected to improve the likelihood of spontaneous eruption of the upper third molars. The lower third molars will need to be monitored carefully. For Class 2 Division 1 cases, the space gained from bilateral extraction of upper first permanent molars can be utilised for these situations and can be considered similar to extracting upper premolar teeth for Class 2 malocclusions. However, removing upper first permanent molars and orthodontics may require additional anchorage control. When there are compromised lower first permanent molars for Class 2 Division 1 cases, it can be significantly problematic, especially in these scenarios. This is an example of avoiding the classic restorative cycle. A 37-year-old patient requested orthodontic treatment and had unrestored upper premolar teeth. The 1/6 and 2/6 were heavily restored and were recommended for extraction. During the treatment, the upper second molars were mesialized and the upper incisor angulation was improved. At the completion of the active orthodontic treatment, complete mesialization of the upper second molars was achieved. And interestingly, despite the age of the patient and mature formation of the 2/8, it still spontaneously erupted. And following the patient for another few years demonstrated the spontaneous clinical eruption of both upper third molars. And this is now 2 years post deband with complete eruption of the 1/8 and 2/8 into functional occlusion. The lower third molars did not change in their position and must be monitored. This unexpected favourable outcome was written up as a case report. Another decision to make is whether to treat with temporary anchorage devices or without. And these are the clinical scenarios where temporary anchorage devices can be very helpful. And these are the clinical situations where temporary anchorage devices may not be required. Use of temporary anchorage devices can be very helpful when lower first permanent molars are extracted for Class 2 Division 1 cases, as this can facilitate mesial movement of the lower second permanent molars without significant reciprocal distal movement of the lower incisors. Such controlled mesial molar movement protects the profile and increases the likelihood of successful eruption of the lower third molars, especially for adolescent patients. And here is one example. A 13-year-old patient with a Class 2 Division 1 malocclusion and heavily restored lower first permanent molars. These teeth were recommended for removal, and temporary anchorage devices were planned in the third and fourth quadrants to achieve this controlled mesial movement of the lower molars. The 1-4 and 2-4 were also recommended for removal, and we can see the temporary anchorage devices being used and now the completion of treatment. The profile was not negatively affected. In fact, the lower jaw position improved during treatment, which is likely a result of favourable mandibular growth. We can see now the favourable eruption path of the lower third molars. For Class 2 Division 2 cases, these patients can be extremely challenging, especially when a lower first permanent molar is compromised. And in general, Class 2 Division 2 cases may be best off avoiding lower arch extractions. And please remember that many Class 2 Division 2 patients have a brachyfacial vertical skeletal morphology. This excellent paper by Hunt and others looked at the muscle composition of different vertical facial morphologies. They found that patients with a short face have a predominance of fast type 2 fibres and are capable of generating higher occlusal forces than patients with normal vertical dimensions. And long face patients have few small type 2 fibres and generate relatively weak occlusal forces. Sometimes we need to think outside the square for brachyfacial cases, especially Class 2 Division 2 patients. And that is where autotransplantation can be very viable, as it eliminates the need to close a large lower arch extraction space. Here is a 17-year-old patient with a Class 2 Division 2 type malocclusion and a profile that would not normally tolerate removal of teeth. This patient also has an over-retained 5-3 and palatally impacted 1-3 and a distolingual cusp fracture and symptomatic 3-6. This patient was to undergo a general anaesthetic to surgically expose the 1-3. Therefore, with appropriate informed consent, the option of removing the 1-8, 2-8, 3-6 and 4-8 with autotransplantation of the 3-8 into the 3-6 extraction site was presented to the patient and accepted. During treatment, 5 months post-transplantation, and a periapical radiograph, and now at 12 months, demonstrating apexogenesis and a healthy periodontal ligament. Now 18 months post-transplantation, and on the periapical radiograph. We can see that the transplanted 3-8 in the 3-6 position will not develop roots as long as the adjacent molars. However, this tooth has not required any endodontic treatment, which is a significant advantage of this technique. And even in the event of failure eventually, restorative implant placement can be considered. 34 months post-transplant. To read more about autotransplantation, these are two articles that have been published in the Australian Dental Journal. For Class 3 cases, careful consideration is always required to determine the severity of the Class 3 dental and skeletal malocclusion. Indiscriminate removal of any teeth for Class 3 cases may significantly compromise or complicate future management. From Coburn's guidelines, it was stated that Class 3 cases are often difficult to manage and ideally require the opinion of a specialist orthodontist before any first permanent molars are extracted. This is an atypical pseudo-Class 3 patient with a significant functional shift from the position of retruded contact to the position of maximum intercuspation. We can also see an over-retained 5-3 and a significantly ectopic 1-3 position. The molars were in Class 3 relationship due to the unerupted and impacted 3-5 and 4-5. This panoramic film demonstrates the restored first permanent molars and impacted 3-5 and 4-5. All first permanent molars were recommended for removal, along with the over-retained 5-3. As the 1-6 was extracted, a temporary anchorage device was placed between the 1-4 and 1-5 to boost the anchorage in the first quadrant to allow effective distalization of the ectopic 1-3. And it was hoped that some spontaneous space closure would occur, followed by orthodontic alignment. And during treatment, we can see favourable movement of the teeth. Cephalometrically, no issues. And now approaching the end of treatment, and now at the completion of active treatment. For compromised lower first permanent molars, we may also weigh up the options of transplantation versus orthodontics with or without temporary anchorage devices. These are the clinical scenarios where molar autotransplantation may be very beneficial. And these are the clinical scenarios where orthodontics plus or minus temporary anchorage devices are likely to be preferable. For a transplant, it is very useful when orthodontic space closure is not desired or is expected to be prolonged or problematic. However, the third molar must be of appropriate size, morphology, and stage of development. And a skilled surgeon must be available. Thankfully, 3D technology can help facilitate and increase the predictability of transplantation. There is no other dental technique or prosthodontic procedure which can offer the biological and bone preservation advantages of successful tooth autotransplantation. This can be very beneficial for carefully selected cases. Indications for use of temporary anchorage devices. When orthodontic space closure is predictable within an acceptable time frame, when the third molar is partially or completely erupted, or unerupted with reasonable angulation. And the clinician can repeat the placement of the temporary anchorage device if failure occurs, unlike molar autotransplantation. These are some review articles on compromised first permanent molars. And to conclude, the presence of significantly compromised first permanent molars is a relatively common clinical scenario in adolescent patients. The etiology and severity of the compromise, analysis of the skeletal morphology, and overall orthodontic treatment needs, along with an honest evaluation of the cost-benefit perspective, are integral to the overall clinical decision-making for each individual patient. I must sincerely thank and acknowledge the following people: Thank you for listening to this lecture.